What we're talking about today is airway evaluation when patients arrive in the recovery room, and what kind of problems you're going to potentially see, and what you can do to make things better. Okay. So if you look at, this is really the only handout that we're going to spend a lot of time on today. This other handout is basically for reference if you just want to go back and look at something. But basically, I've divided the airway issues into obstruction, hypoventilation and apnea, loss of reflexes, and laryngospasm. Now, obviously, as you know, you can have more than one problem at the same time. And sometimes, you might have a hard time deciding which one it is, but at least it gives you a starting point when you're evaluating a patient. Okay, so let's talk about obstruction first. What causes airway obstruction when a patient comes out of the operating room? The most common thing you're going to see is that the patients are just really sleepy and they've got all these, like Robin, all the soft tissue back here is just kind of getting in the way of the air going in and out. Now, obviously, that's going to be a bigger problem if you have a patient that has sleep apnea or somebody who's obese, and hopefully we don't have too many pregnant patients here. But those patients are going to be, see somebody roll through the door, and you can see that they're really large. I mean, that's going to be one of the first things you're going to think of is, okay, that patient's going to obstruct easier than some other patients. So what do you see in those patients? You're going to see that there's respiratory effort there. You might see some retraction of some of the muscles of respiration, like the chest, and but not a whole lot of air is going in and out. So they're trying, okay, but the trying just isn't working. If you have a face mask on them already, you're not going to be seeing the misting, or you'll see some misting, but not very much. You might hear snoring, and eventually they're going to turn blue, okay? So how are you going to fix that? The vast majority of the time, it's as simple as just a finger under their chin. You just lift their chin up, or chin up and head a little bit sideways like that. Or you could something as simple as putting a towel roll underneath their shoulders. Getting rid of the pillow. If they're obese, put the head up a little bit, get their stomach off their chest. Those are just some really simple things. You don't have to dive at them and have hands all over their face. Yeah. Just simple things. Like I said, one finger on their chin is sometimes just the easiest thing that you can do. If those simple things don't work, then go to a jaw thrust. That might be the next thing that you need. That doesn't work, or you're getting tired of holding it and you have other things you do, you can put an oral airway, you can put a nasopharyngeal airway. Patients tend to tolerate a nasopharyngeal airway better, especially if they're starting to wake up, because it doesn't irritate them in the back of the airway as much. While we're talking about it, let's go to, I think, the last page of the other handout, and there are actually a couple of pictures there. The best way to get an oral airway in is to use a tongue blade. Push the tongue down and just slide it in. If you just try to slide it in without a tongue blade, then you risk pushing the tongue back and making the whole thing worse. You can put it in backwards and flip it around if you know how to do that. If you don't know how to do it, I wouldn't try it on a patient who you thought was going to be in trouble. I get somebody else to try it.
Do we have a tongue blade in all our bays? I guess that's the question.
We have some tongue suppressors, but I don't think they're at the bedside. I was just
There
should be.
Yeah.
No, well, there should be, yeah, but I've had to panic, grab gauze to pull it out the tongue. because
That's a tongue blade. Is it?
Yeah.
Yeah, there should be.
Yep,
Yeah.
exactly.
We have to check.
That's
it.
right,
yeah.
And then have we done it? I mean, with our teammates, are they comfortable putting an airway?
Not everybody is.
Yeah. So
Maybe you should, I don't know, have a checkoff list.
Right, and in service of-
figure out who needs to
Yeah.
learn how to do that, and when it needs to be done, call that person and say, okay, come on,
Yeah.
let's, or we could take them back in the OR and let them
Right.
learn how.
So I think that's something, Dr. Sprengel, because I want to make sure that you know, we're not just preaching it, tell them, oh, you know, just go ahead,
Yeah.
you know, do it. And
Right.
I think we want to see if they're really competent
Mhm.
on putting in an airway if we're gonna do this, and I think an in-service for that and check off,
Yeah.
you know, that they're
Who knows,
okay.
who knows how to do it?
Yes, yeah, okay, all right.
Okay, so the next one is hyperventilation and or apnea. I mean, they kind of lead, one leads to the other. Probably the most common thing you'll see is that it's due to sedation and residual anesthesia. You know, there are, what makes you breathe? Your oxygen levels are down, but another big one is your CO2 level. Big driver, when your CO2 level goes up, it makes you breathe. And the drugs that we give actually blunt that response, and so your CO2 level has to go even higher to make you breathe. And you know, so if you have drugs that are blunting that, well, you know, patient may not be breathing as well. If they're completely apneic, the thing that you need to worry about most is, I think, paralytic agents. And do you guys know which patients we paralyze?
No.
Well, see, I think you should know that. So let's start a list. And not all of these are gonna be, but ENT patients are always suspect. You know, always suspect. I've got a little list here for you already.
Oh, they're in there?
They're,
Oh, good.
they're already, yeah, they're written down. They're always suspect.
Alright.
If it's short, like a tonsil, you know, I usually don't. My tonsils, I don't think I paralyzed any of them today. But bigger ENT cases that we intubate, it's basically people that we intubate. Any intra-abdominal, so laparoscopies, whether it's a gallbladder or a laparoscopic hernia repair, whether it's a, you know, for tubal ligation, those are all suspect for having been paralyzed. Total shoulders, they want those patients paralyzed up the wazoo. I mean, they want more paralysis on those patients than you ever heard of.
Just shoulder specifically as opposed to a total knee or hip?
Yes,
Oh.
yes. And hip arthroscopies, they do anything where they distract the hip out of the joint or the shoulder out of the joint, which is not something they do with a total knee or even just a total hip, because they're taking it out. So those surgeries, they want tons of paralysis on, and we're always like, man, are we even gonna be able to reverse them? You know, we're always worried about that. Cosmetic stuff, if it's facial cosmetics, those patients most of them are intubated, so we're gonna paralyze them. But even, Dr. Bowie likes some paralysis on his abdominoplasties, on breast augs, for a little bit, not a lot on that, but for a little bit. And then peds dental is another big one. You know, we always intubate those patients, but those surgeries are so long
Yeah.
that usually that stuff's way gone by then. So, you know,
Just a quick question.
Sure.
So if you're using an LMA, you never paralyze?
typically no.
Okay.
Yeah, except, I mean, I use an LMA on the abdominoplasties and those things, but still, he likes them paralyzed just for a portion of the surgery, not necessarily the entire surgery. But if we're intubating, plan on us paralyzing the patient the majority of the time.
Okay,
Okay.
makes sense.
So, when these patients come in, they're not making respiratory effort, you know, or just barely making respiratory effort. No misting. So as opposed to the last ones who were trying to breathe, these are typically not trying to breathe. And they may be a little tachycardic, and they're probably getting blue, you know, a little faster because there's no effort there at all. What do you do with these patients? Well, you know, there's a good old sternal rub. You know, you can try to stimulate them, you know, see if you can, but you can't stimulate somebody out of being paralyzed. Can't do that. You know, if it's just from the other anesthetic agents that we use, yeah, you might be able to do that. So shy of that, you've got to get out your ambu bag and start bagging them. There are to be able to, this one actually overlaps with the other one down below. If you think, you know, when patients come back and they're not fully reversed, as far as the paralysis is concerned, you'll see they're just kind of twitchy. You know, you've seen that?
Yeah.
Hopefully not
Vaguely,
often.
yeah.
And if they're awake enough, you can ask them to lift their head. If somebody can lift their head up off the bed and hold it for, a few seconds, they're strong enough to breathe. Okay, so that's not gonna be your problem. And the other, you can ask them to, squeeze your hands and stuff, but that, to me, that's just not, they're not gonna be quite as cooperative with that as, raising your head, that's something that's easily defined, not is this a strong enough grip.
Right.
So you can see if they can do that. If you
Yeah,
have
cause
to,
you can have if you can't breathe, they're holding on to your hand, right, if they
Yeah.
can't breathe.
Yeah. Okay, so I want you to go to the third page of that other handout. And I want you to look at how that guy's, since we're talking about, mask bagging patients, look how that guy is holding that mask. And you'll see anesthesiologists hold it wrong all the time. And I don't expect that you'll remember to do it correctly, in the heat of the moment, except that if you're having trouble, you think, why can't I do this? You'll see people that will, try to grab the mask like this and maybe get one finger down underneath the jaw, and then try to press down on this, face mask really hard. That, your arm just gets tired, and then you can't do anything. But if you put one finger here, and then get these 3 fingers down underneath the jaw, and you'd be amazed at how little pressure you actually have to put down with these fingers, because you're doing more of the pressure up with these bottom ones.
It's the EC hold.
Yeah,
Yeah,
Right?
yeah, okay.
yeah.
So just, if you can try to remember that. And the other thing is, if you're having a hard time with a seal, put that face mask down there on the patient, and, with 2 hands, hold like this and have somebody else bag.
Okay.
Get 2 people at it.
Yeah.
Okay.
And which may be, easier for you guys that don't do it all the time.
Yeah,
And even if you have like a really big person, like a big man that's large and stuff, even in the operating room, sometimes it's like, yeah, I can't do that. We've got to maybe 2 hands and get enough to bag them. Okay, so loss of airway reflexes. That will lead to aspiration if you're not careful. So, that's the big thing here. What causes loss of reflexes? Deep anesthesia, and then again, paralysis, as far as the anesthetics are concerned. That's so the same things that cause hypoventilation or apnea are the same things that are gonna have you lose your reflexes. But in addition to that, the surgeon could have been operating on the vocal cords, So you gotta think about that with that. Or a patient may have a paralyzed vocal cord. And that's something that your anesthesiologist should get a history of before surgery and should tell you about when they drop the patient off. That should be part of the report. This patient has a paralyzed vocal cord, and you're gonna be going, oh, aspiration, can they control their airway?
You'd be
A
surprised at some of the lack of report we get.
Yeah.
a paralyzed vocal cord from,
From some other injury or some
Okay.
other thing
Okay.
that, doesn't have anything to do with.
mhm.
And the problem with loss of airway reflexes is it can be just really insidious. The patient can be just laying there, just breathing normally, you have no idea that there's a problem with their reflexes. They look perfect.
Oh, I see,
They
I
look
see.
perfect.
Okay.
The next thing you know, the little bits come up and gone down. You kind of didn't even notice. It just kind of snuck up on you. But one other thing is that if you see a patient that is, like making faces or like raising their eyebrows, their eyes can be closed, but maybe they've got an oral airway in and they're raising their eyebrows, their airway reflexes are fine.
Oh.
If they can do that, then they're fine, unless they're paralyzed. But if it's just from the anesthetic agents themselves, they're awake enough that they should be okay for it. So, these patients, if there's any clue that reflexes are a problem, you really have to watch them closely. And, if you see secretions, get your
Suction.
doctor out and suction, yeah. So then the last one is laryngospasm, and it's the one, It doesn't happen that often, but it's the one that just like scares the pants off everybody. Even though some of these others can be just as bad as laryngospasm. That's the one thing where everybody's, oh my goodness. The biggest cause of that is stimulation of the vocal cords. So what causes that? Secretions will cause it, blood will cause it, suctioning will cause it. So there's a big question, if you think there's something down there, do you suction and maybe cause laryngospasm? Or do you let it sit there and maybe, it's the secretions that are gonna cause laryngospasm, and which one do you do? And sometimes we have that quandary even in the operating room. So if you decide to go suction, you just wanna make sure you're gentle. Gentle, yeah, exactly. And oral airway can cause it. Just, putting the oral airway in will cause it. So you gotta be super careful about that. The other thing is that patients will have an irritable airway up to 6 weeks after they've had an upper respiratory infection. And you think that's like, oh, well, they're over it. Well, no, they're not over it. And so, they'll go into a laryngospasm for like no reason at all. It's like you look at them and they'll go into laryngospasm. So what you see with these is they're trying to move air. Just like the obstructions. This is just a different kind of obstruction. They're trying to move air, but they can't. You might hear some inspiratory stridor. You might hear that, which means they're moving a little bit of air. And of course, the misting is not going to be happening. When you look at the treatment, you're going to see I put down 100% oxygen. Well, everyone's going to have 100% oxygen. I put it on this one specifically because you want that 100% oxygen there. So if the patient does take a breath, the first thing they get is oxygen. Okay? And the standard way that you break a laryngospasm is by holding a mask on the face and then just putting some even pressure on the bag. Ambu bag, our bag, reservoir bags in the operating room, even pressure, and that gentle pressure, just even gentle pressure, just hold it.
No squeezing, just.
Yeah, if you squeeze it, nothing's gonna happen. So you just hold it, because then if the patient breaks just a little bit, something will go in, okay? So it's kind of the standard way of doing it. Now there's a I wanna say relatively new maneuver, it's called Larson's maneuver. And what you do is right here behind the ear on both sides, you just jam your fingers in there. And usually within a couple of breath attempts, it'll break the laryngospasm.
And usually when you're trying to do the jaw thrust, when you do that, to open it up, that's.
Yeah.
So you're doing that without lifting the jaw?
If you can do a jaw thrust at the same time, give it a little bit of jaw thrust, but just press your fingers in there.
Yeah.
And there's no, I haven't seen, where anybody's really been able to figure out why doesn't that work.
Okay, yeah.
Works. It may be just enough that you're hurting.
I was just
really
saying, it feels
badly.
like more of a
And-
painful
And
stimulus.
it may be that if you do some other super painful stimulus, it would be the same.
Yeah.
But we're up there at the head.
Yeah.
And that works. And
Yeah, because that's what we usually do, we're trying to get their jaw, and that's
in
probably
the
that
process,
pressure
but
behind it.
it's way up here underneath. So, we walk in to bring a patient in recovery. How are you guys gonna evaluate the patient? Just
Look at 'em.
throw it out there. Look at
Immediately
them.
look at them as you're wheeling
Look
them
at them.
down.
And what are you looking for?
Do they have an airway? Do they not? Are they awake? Are they not? Are they breathing? Are they
Okay.
not? Are you
Yeah.
bagging them or are you just looking at them?
Okay.
Yes, their chest moving.
Chest moving, perfect, okay,
Are they drooling?
okay.
Fogging?
How about what their color is?
Color, of
Color,
course.
yeah, we like
Of
color.
course.
Yeah.
O2
No, you
cell.
guys are good. Yeah, so why don't we talk about that?
Well, usually they're not hooked up until we get them in the room,
That's
so.
right, because
yeah.
they're not, they're in the process of being hooked up, they're not hooked up yet.
Yeah.
But the other thing is the pulse ox, there's a lag, and so it's always behind. It's always behind what you're doing. If patients are getting worse, their pulse oximeter may still look pretty good. And by the time it starts falling, you're in trouble already. When you fixed a problem, there's a lag with it coming back up. And so, you maybe keep trying to fix it because you don't like what the number says, but guess what? they're pink, you know, and you can see that they're misting, and you can see their chest move, and, you know, so they really are okay.
Yeah.
You can just, one other little point, if you don't like the number up on the machine for the pulse oximeter, men have big fat fingers sometimes, not all men, but a lot of them do, and so if you take the pulse oximeter off the index finger, put it on the little finger, you may get a better reading. Put it up on the ear, you guys all know that, that's nothing new for you, but just a little reminder. Questions?
Well, I'm encouraged to see that the goal is to keep the SAT above 90. I've always
Well,
thought,
yeah, you know what, with the SAT of 90, you still got the oxygen mask on, it's not like we're sending the patients home,
Mhm,
but at least you can take a breath and go, okay, now, we aren't in such a hurry,
right, okay,
okay?
got it.
You know, you're gonna keep the oxygen on the patient until they're probably 94, you know, and then kind of
Start to wean them off.
start getting them off.
Okay.
Okay, any other questions?
No, this is good.
I know we have a struggle with, like we said, Dr. Sprengel, with, you know, checking the pulse oximeter, right? What's the chances of, because I'm not sure how accurate it is if we're putting it on the ears with that specific clip versus us having those little stickies, the wraparounds. I'm not
Yeah.
sure if we do use it here.
We do have some pediatric ones,
Yeah,
but I
We have
use
adult
Yes.
ones, we have adult ones too
Yeah.
somewhere.
Don't let them get hypoxic.
Or you can also with a clip try
She
it.
doesn't know that
That would be
she's-
great
Yeah,
if she's on
yeah.
camera.
Because that's what I would do, like what we do
A
Right.
little
with kids.
comedic,
Yeah.
whatever.
Yeah. Okay, we
Yeah,
good?
yeah, great. Thank you, thank you.
Thank
You're
you.
welcome.
All right, thanks, Dr.
You're welcome.
Sprengel. And then
Thank you.
if we have any other concerns, I mean, she's really nice enough to,
Yes,
you know,
thank you for
just
doing that.
answer all our questions.
And thank you for telling us about the paralytics versus them, being more
Yeah.
attuned to like having respiratory problems, because that's not even told, first of all, that's not even told. But
Yeah.
we
Well,
don't get told that the patient
but-
has paralytics or anything, they're just nothing.
Yeah,
The nurse will say everything's
Yeah.
fine, no allergies, we gave
There's-
you this, and that's it.
right, there's, if you look at the anesthesia report page, there's a little thing for us to check that says paralysis reversed.
Oh,
I don't know if people circle that little thing or check it or
I'm
not,
gonna look at it now.
you know?
But you don't always have to reverse it, like sometimes it's just been a while and it's
Well,
done.
that's right, if it's so long since we've given it, then it's gone. In fact, you might get yourself into more trouble by reversing it. Because the reversal agents, if there's nothing for them to reverse, they can cause some weakness on their own.
And then can you tell us
So-
again, Dr. Sprengel, what's your criteria of reversing your patients? Why would you want to reverse
Well,
versus
we
not?
have that little nerve stimulator that we put up here, and to see what kind of,
Okay.
a tetanus, usually a tetanus, and if it really, cranks up the muscles and they hold, and they don't go away, then your paralysis is gone enough to extubate them. But if you do a twitch up there and it goes like that and then fades really fast, well, they've still got some paralysis on board.
So most of the time, before you're bringing them out, you have checked to see that the paralysis has worn off?
I have, unless it's been a 3-hour case and I gave a tiny little dose just so I don't damage the cords when I put them in, just enough to relax the cords, but not necessarily enough to kind of relax the whole patient.
What paralytics are we using here?
Rocuronium,
Rock, yeah.
acuparium, we have succinylcholine, but
Right.
I don't think people use it much.
Okay.
And there's no reversal agent for that, so you just have to let that one wear off, but it wears off really fast anyway, so I think those are the only ones that we have.
Okay.
All right.
Okay?
All right. Thank you very
Thank you.
much.
All
All right.
welcome.
Thank you, Dr. Sprengel.
You're welcome.